Good afternoon, everyone. There I am. Thank you, Tammy and Brianna, for that wonderful overview of the AZOHC. I was hastily adding in some links in the chat to our website and a link to join our newsletter. So make sure you check those out. And we will go right into our next panel. So our next panel brings together a really fabulous group of advocates, champions, and innovators to talk about oral healthcare workforce models. So it's my pleasure to introduce this panel's moderator, Julia Wacloff. Julia is the Program Administrator and Chief of the Office of Oral Health, Bureau of Women's and Children's Health, Division of Prevention Services with the Arizona Department of Health Services. She provides oversight of dental public health initiatives and has over 20 years of experience in various public health settings, providing workforce development, disease surveillance, and quality assurance at local, state, and national levels. She is currently the president of the Association of State and Territorial Dental Directors and participates in an advisory and technical assistance capacity to other state oral health programs. Thank you so much, Julia, for joining us today and moderating our panel on oral health workforce models. You can go ahead and take it away, Julia.
Well, thank you, Tara. It's a pleasure to be here this morning. It's still morning. These are great topics so far, and it's really evident that in order to see health systems transformation for oral health, it needs to occur at multiple levels across a variety of sectors. And the sector, as Tara mentioned, that we're covering, that the panel's covering today is workforce. Currently, 3 million Arizonans live in HRSA-designated dental health professional shortage areas, and innovative models are a key way to reach these populations who otherwise cannot access dental care. In July 2022, the ADA Health Policy Institute released a report citing staffing issues as the most significant concern among dentists. These shortages have caused an estimated 11% reduction in dental practice capacity, and there exists a need in shoring up the workforce pipeline to address the long-term needs of our populations. Other data driving the demand for care includes oral health status indicators for Arizona. The ADA Health Policy Institute report on oral health and well-being for Arizona found that while 99% of adults value oral health and 95% agree dental visits keep them healthy, more than 30% felt their oral health was in fair to poor condition. In addition, oral health remains a challenge for Arizona children, with more than half of Arizona kindergartners having tooth decay experience by the time they start school, a level which is higher than the national average for 5-year-olds at 36%. These factors, along with the workforce shortages, bring opportunities as well as challenges to our state. Today, our panelists will share some of their challenges and opportunities on how Arizona can move forward. And now I'd like to take a few minutes to introduce you to our panel members. We have Kristen Boilini. Kristen is the managing partner of Pivotal Policy Consulting, a full-service public policy and government relations firm. Kristen has represented clients in various public policy arenas for over 20 years. She has an MS in economics, an MA in human development, and a PhD in organizational development. Kristen's practice is quite diverse, where she works with a variety of clients in areas ranging from education and higher education to healthcare, tribal and municipal governments, housing and economic development interests, as well as the business and nonprofit sectors. Welcome, Kristen. Ms. Kim Russell. Kim is of the Bitterwater people, born for the Tangle people. Her maternal grandfathers are of the Coyote Pass clan, and her paternal grandfathers are of the Bitterwater people. Ms. Russell is from Chinle, Arizona, and a citizen of the Navajo Nation. She is the director of the Arizona Advisory Council on Indian Healthcare an independent state agency whose mission is to advocate for increasing access to high-quality healthcare programs for all American Indians in Arizona. Kim has worked with tribes, tribal organizations, the Indian Health Service, and urban Indian health programs to advance their health agendas and priorities her entire career. Dr. Brianna Hillier is the Director of Dental Services for Chiricahua Community Health Centers, a mission-driven, federally qualified health center, ensuring all people in rural southeastern Arizona have access to dental care. Dr. Hillier has more than 15 years of experience in dentistry, serving in both private and public capacities. She believes all people have a right to access excellent dental care regardless of their ability to pay. She has dedicated her professional life to providing exceptional dental services to everyone. And MiQuel MacRae. MiQuel graduated from Rio Salado Dental Hygiene School in 2001 and has been practicing ever since. After moving to rural Arizona, she founded a nonprofit called ToothBuds, Bridging Understanding of Dental Disease in Schools. ToothBuds is a school-based dental hygiene program utilizing affiliated practice dental hygienists to take the dental chair into areas where it is most needed. ToothBuds now provides services in Graham, Greenlee, and Maricopa counties. Her conviction about the importance of preventive dental care has grown exponentially after leaving the comforts of private practice and venturing into the world of public health. Welcome to the panel. So the first question for the panel is to provide a high-level overview and the key innovative workforce model that you bring to the state. And we'll start with Kristen.
Thank you, Julia. It's nice to be here with everyone, and it's great to see some of my fellow oral health advocates. I love these webinars because I learn so much about what's happening across the state and the good work that you're all doing. I come to this arena from a little bit different place, not being a healthcare provider myself, but really being an advocate for health services in the state of Arizona. In addition to the work that we're doing around dental therapy, which I'll talk about in just a moment, we do also represent the Alliance of Community Health Centers and the American Congress of OBGYNs. My role in oral health has really been focused on dental therapy and providing a pathway in Arizona to incorporate this new type of dental professional into our dental team. So similar to the way the medical profession has incorporated nurse practitioners into their service model, we're hoping to get dental providers to incorporate dental therapists into their practices to help expand care, to help expand hours, to help bring care closer to the communities that need it, the medically underserved and rural communities across our state, and to do that with a provider that's frankly less expensive than a dentist, allowing dentists to work at the top of their scope, allowing dental therapists to come in and fill some of the hygiene and restorative care services that are lacking in our dental teams and across our state. So if you're not familiar with the dental therapy model that we have in Arizona, it's a hygiene-based model. So in order to be a dental therapist, you have to be a dental hygienist. And then you incorporate that entire hygiene scope along with the dental therapy scope that allows for some restorative procedures and an extension of what hygienists can do. So my team and I worked with a number of you in this webinar and a number of the panelists in working to get a bill passed to allow dental hygienists or dental therapists to practice in the state of Arizona. Once we did that, I know a lot of you and I worked together on getting the rules package done so that BODEX could implement dental therapy licensure and regulation. I want to shout out to all of those of you who worked so hard. That rules package is finally done. I know we didn't think for sometimes that it was going to happen, but it is finally done. I was really excited to listen to the panel on integrated care and integrating oral health care into medical visits, and that hygienist that taps on the door and comes in, does a screening, talks to patients about their oral health. We believe that dental therapists are going to be able to provide that same type of service because they have that full hygiene scope, but then also provide additional flexibility for smaller community healthcare clinics, smaller volunteer clinics, where that individual, that professional will be able to be utilized working on hygiene as well as the restorative procedures. So now that the rules are done, we'll be shifting our role to implementation and making sure that all of the work we've all done on getting that legislation passed, getting those rules done, actually means that we'll get dental therapists working in the state of Arizona, and we're very excited about that. When we were initially working with the Pew Charitable Trust, their motto was, we just need someone who wants to be a dental therapist, someone who wants to train a dental therapist, and someone who wants to hire a dental therapist. So the work that we'll be doing in coordination with the Alliance of Community Health Centers will be to try and coordinate, provide resources and support for individuals who want to become a dental therapist, entities that want to educate a dental therapist, and then also providers who need to understand how to incorporate dental therapists into their dental team to expand access to care. I think, as most of you know, as additional states have come on board and more states are passing dental therapy legislation and putting rules in place, more education programs are looking at dental therapy, but also more national organizations are adopting a dental therapy priority, including the National Association of Community Health Centers. So as more of these groups get interested in dental therapy, there will be more resources and more support out there for states who are really trying to implement and incorporate dental therapists. So part of what we will be doing is coordinating with those resources and supporting all of you in the work that you do, and really trying to make sure that what we spend all of that time on getting done actually comes to fruition in Arizona. There are a couple of things that we need to be doing simultaneous to that. We need to work with Access to make sure that Access submits its state plan amendments so that they can actually reimburse for dental therapy services, as well as ensure that IHS, Tribal 638s, and urban Indian health clinics are able to utilize dental therapists and get reimbursement through Access. So very excited about this new profession and very happy to join all of these wonderful advocates doing the great work you're doing.
Thank you, Kristen. I know following the rules process can be quite challenging sometimes, and having you provide the update is really helpful. And I see that Brianna just put in breaking news in the chat that dental therapy rules have just been approved by the Governor's Regulatory Review Council and can officially practice in Arizona as of July 10th. So perfect timing.
Perfect timing.
Yes. Now we will move on to Ms. Kim Russell.
Hi, everybody. Kim Russell with the Arizona Advisory Council on Union Healthcare, but a longtime member of the Arizona Oral Health Coalition. Happy to be a part of all the efforts we've been successful in gaining in Arizona, and more to come, obviously. I do want to share maybe a few things from more of a tribal Indian health service perspective that, you know, we've been talking about for quite a while. Obviously, dental therapy, working really closely with Kristen and her colleagues, and just really all the different advocates across the state to get dental therapy signed into law. Really proud of all the efforts that we undertook to do that. At every committee meeting, there was a tribal leader who was providing testimony. We had one tribe whose tribal leader flew in from Albuquerque, New Mexico to be with us so that she could provide her 2 minutes of testimony. That's how dedicated our tribes were to getting this law passed. Picture up at the airport. She did her 2 minutes and then she was out. So really appreciative of the Navajo Nation for being that committed and publicly attesting their support before the legislature. So dental therapy has been on our radar for many years, even before 2018, because we were following a lot of the example that was happening in the Washington state with the Swinomish tribe. And that Swinomish tribal leader was really advocating for dental therapy to all the tribes across the nation. And so I think without that tribal leader, we probably wouldn't have had knowledge or interest here in our tribal communities. And then of course it translated into our state of Arizona. So really happy that we were part of that statewide effort to get dental therapy passed into law. I always say it's easier to pass the law. The implementation part is the difficult part, right? We talked about the rulemaking part and how long that was. And there's some things we weren't able to get in. We're 5 years post the 2018 law being signed, and we don't have a dental therapy therapist practicing yet. So there's still work to do. Kristen talked about the Medicaid reimbursement thing. There's just so many more steps for us to realize dental therapy. But in our tribal communities, we're very well aware of the model. Another extra step that I think some of our tribes would have to take that not necessarily non-tribal dental therapists might encounter is we would have to set up our own kind of oversight board. And that would be done through the community health aid program. It would be an oversight for providers within not only the dental health discipline, but also the behavioral health discipline and the primary care discipline. So I think in total, there's about 11 or 12 mid-level professionals who would be not licensed, but certified underneath that community health aid program. IHS is still standing that up. Here in Arizona, we're still trying to discuss what that might look like, but I do believe Navajo Nation is a little bit, maybe one or two steps a little bit further in that process. So that's an extra step that we would have to do here in our state if the tribe wanted to go that way. The way that the law is written, though, is that we could go through the state process as well. Each tribe will have to decide what's the best way to do that. I think some of our conversations about dental therapists and how do we implement that into our tribal programs is, what about dental therapists that are already certified in other tribal jurisdictions? Because we do have some of those. We've already had some outreach from dental therapists that used to work in Alaska. Then they came to, I believe, maybe Washington State, wanting to come here, but we're not ready to receive them. So there is interest to work in our tribal systems. We're just not set up yet to provide that oversight for them, let alone like the Medicaid reimbursement part that we're still having to cross that bridge. So there is interest. There's just a lot more steps for us to get there. I mentioned that the community health aid program consists of like 12 different mid-level providers. Within the dental health discipline, I think there's like 3 or 4. So it would be only for the Indian Health Service and tribal systems, though, those providers. And we call them dental health aides. So I think, well, first of all, in Arizona, we call them dental therapists, but in the Indian Health Service system, we call them dental health aid therapists. It's a little bit different with the name. And then with the other disciplines within the dental therapy, it's like dental health aid 1, dental health aid 2, dental health aid 3, I believe. And they look very much like some of the workforce models that we already have, just a little bit different in terms of how they're trained. And then, but we're taking a look at that. We're really looking at Alaska. We're looking at the other tribes have moved forward with this, and the Medicaid, I guess some of the Medicaid battles they have in their state, but they're proving to be favorable for a lot of our tribes. I think there's some district court rulings that sided with the tribes that these services are reimbursable. So there's still a lot of, I guess we're watching other tribes, right, in other states of what they kind of look like. So definitely we're very into dental therapy. I know I'm kind of, I do want to mention really quickly, because I might dive into this a little bit more. But the other model that I'm really excited about, and I think I might have heard it and saw it in one of the comments, was how do we work with our community health workers? And for our tribal communities, that would be our CHRs, our community health representatives. How do we work with that workforce, which is plentiful for some of our tribes, and also with this workforce, it's us. You know, it's our people who are these community health representatives, we don't necessarily have to worry about a language barrier. We don't necessarily have to worry about training them to know the community. There's a lot of pros for this workforce, right? They're already kind of ready, set to serve in our communities, but how do we work with them in the oral health field? So really excited about that. And then lastly, and I'll dive into this a little bit more perhaps, is we are just standing up. We are not even a year in, but my agency is standing up an area health education center. So we're the 6th area health education center here in the state of Arizona, and it's going to be just specific to the tribal Indian healthcare system. So really excited to set that up. We are going through a strategic planning process to figure out, what are our priorities? What do our priorities look like for our American Indian Health AHEC? I'm hopeful that we will include oral health. The one thing that I do want to say is in our communities, and I know a lot of our communities throughout Arizona, is we have health professional shortage areas in so many different areas, let alone just oral health, right? And I think that's the advocacy that we need to make sure we do, is that we include oral health into that new American Indian Health AHEC, because we already are hearing really loudly from our tribal colleagues that nursing, we really need to ramp up nursing. And behavioral health providers. I hope we get oral health in there. There's just so many competing priorities that I'll be honest, I wouldn't be surprised that in the first couple of years of our AHEC, we don't include oral health for a number of reasons, right? And I think it leads to some of the like, for instance, we need to build up our system as well, our infrastructure for oversight of our dental therapists. The other thing is the reimbursement for that provider. But I think we're making strides towards that. I'm very hopeful that we will have our oral health providers as one of those priority workforces that we're going to focus on with our area health education center.
Thank you, Kim, for those updates and bringing the tribal and American Indian perspective and their unique challenges and the opportunities around the AHEC that you will be establishing. That's wonderful news. And now we'll move on to Dr. Brianna Hillier.
Good morning, everyone. Brianna Hillier down at Chiricahua Health Centers. I just wanted to take a couple minutes here regarding probably the same, like I said, same issue that everybody's having. All those stats that Julia kind of rolled off at the beginning here are very much affecting us down here. And we've had to get very creative. I am not inundated with resumes left and right. If anybody is, go ahead and let them know that it's always sunny in Cochise County. But we've had to get creative, and so we really experienced a major workforce crunch after COVID, and particularly with my dentists and dental assistants. And so what we ended up doing, even prior to COVID, we have a career path that our dental assistants can take, as well as our, we also have one built for our front desk, our patient service representatives. But a lot of people are looking to grow. A lot of people don't want to remain stagnant in their careers, and so what we found was that if we built a career path or a career ladder where we can grow our own, and or from the outside people can have experience to grow, we found that that's working out really well for us. So with each tier of our career ladders, there's more job duties, more certifications, depending on what they are. Our organization will help pay for it. We've also worked with the Arizona at Works program, and they will help train, anybody, basically someone off the street who has no dental knowledge, and give them an online dental assistant certificate, which, 15 years ago, I thought was kind of silly, because how can you get a degree for hands-on experience virtually? And now we have some of our best dental assistants who have graduated from these online only programs. They then come and see us for their externship. So, we're really, as everyone has kind of already touched on, utilizing the peak of our licenses. All of our dental assistants get corona polished. I don't inundate a hygienist schedule with SRPs and harder procedures, but the 5-year-old doesn't need to go on the hygienist schedule. The 5-year-old stays on the dentist schedule with a corona polish. They do the exam, they do everything wham bam. And that way the hygienist schedule, which is, very important, and I've got hundreds of patients, thousands of patients trying to get in, the hygienist can focus more on those patients, those adult patients that need it, or the pediatric patients with braces and lots of calculus. So really tried to kind of change up our scheduling regimen, because it used to be anybody getting a cleaning went into the hygienist schedule, but I just can't, I'm too busy at this point to I need to be able to utilize them more, like we said, to the peak of their potential. I promise for the hygienists out there, I do not book their whole schedules with SRPs. They've got a couple a day because I don't want a bunch of surgical extractions, so I totally get it. But it's worked out really well. We've been utilizing integrated dental models for several years. We've got mobile units. All of our hygienists are affiliated practice dental hygienists. They come on board as an affiliated practice dental hygienist. It's worked out very well for us. They can get into the nooks and crannies of the county and, utilize teledentistry, which I'm sure Dr. Howell's going to just go to town with later, but it's really innovative. And for those of us that have been using it, it's great to see that other people are also getting on board with it. But one thing I was going to say really quick, and then I'll be done, is the adult patients that we have seen in our health center has just gone up astronomically. We're running into thousands of adults with these Medicare Advantage plans, and these are patients who have not had any dental insurance for decades. And now they've stumbled upon $4,000 and they get to utilize that. And we want to be able to help them. But it's hard. And so what I'm finding is, I'm definitely here for the dental therapy model. I'm also on the state dental association's Council of Government Affairs. And I get up and I say the public health perspective that a lot of private practice docs either don't want to hear or aren't even thinking. And it's not to be seen as a threat. Everything is working together. As long as the patient has a dental home, that's all I care about. I don't care who they go to, and that's the point behind this. And so, I'm dipping my toes in a lot of, kind of policy and advocacy, and I really enjoy it. So I'm excited to see where this goes. But yeah, we've had to get creative with our workforce, and I'm hoping that the career ladders. We've just added the expanded function dental assistant / auxiliary, because I know somebody mentioned it's good to include the hygienists in that, because I do have hygienists that are interested in, and kind of same thing, they want to be able to grow a little bit. So whether that's as an EFTA or whether that's as a dental therapist, I'm here for it because I need the help and our patients need the help. So we've got to get creative with how we are able to, meet the needs of our communities.
Thank you, Dr. Hillier. I can express that you are not the first dental provider from an FQHC who has expressed their workforce challenges, and I've heard it many times, and appreciate all the efforts that you're putting forth in Chiricahua. So now we'll move on to Ms. MiQuel MacRae. MiQuel. Hi.
Hi. It is such a privilege to be on this panel with all of you. I consider me the boots on the ground. I'm the hygienist who I implement all the hard work that you guys do in the legislation to get things passed so that we can actually get out in the field and do some good work. I can relate to the shortage. In 2020, we opened up Gila County. Gila County is Globe, Miami, that area, and we were working, and then COVID hit. And after COVID, we unfortunately lost our hygienist because she needed full-time work. And when she could no longer work for us, she had to leave Tooth Buds and find full-time work. And so we no longer are in Gila County, unfortunately. And there's no longer an access provider, dental care provider in Gila County. So it was kind of a double whammy, unfortunately, because we were seeing the kids and then sending them to the access provider there. But I'm really excited to hear about dental therapists. So in 2018, when dental therapy passed, and Kristen, I wanted to address this to you because you mentioned finding people who could use a dental therapist. As we go out into these rural communities here in Graham and Greenlee counties, and now Maricopa as well, there's only so much we can do as hygienists. I'm finding that there's two groups. There's the parents who get our referral and go to the dentist, and there are the parents who throw the referral in the garbage, and those kids never see a dentist. And the kids with the most urgent needs are not getting those needs met. And so as much good as we can do, we're providing the prevention, we're educating, we're doing everything that we can do to try to connect these patients to a provider, there is a large majority that it's never going to happen. And so with dental therapy coming on board, it is a game changer for a practice or for a nonprofit such as ToothBuds, where we're going into the field and we can then use teledentistry to communicate with our dentist, bring the dental therapist along, and help those kids that need it the most. The good news of that is our community here is so excited about it. In 2018, when I mentioned it, one of our donors actually said that they would pay for one of our hygienists to go to dental therapy school. So, hey, let's get it. Let's do this. So that's really exciting. Kim, I wanted to bring something up to you that might help push oral health care along in the, I think you mentioned the AHEC. Excuse me, I'm not as well versed in that field, but one of the things, having been a hygienist for all these years and working in private practice, you don't know what's outside of the walls of your little operatory. And, ToothBuds started because I learned that Greenlee County had the worst oral health statistics in the state. And that's where I live, that's where I'm from. And so that's why ToothBuds was started. And something I learned from the community as I started this, I spoke to the Graham County detention counselor, and he sits with all these kids that are in juvenile detention, and he sits in a circle and he counsels with them. And he came up to me after I got my very first grant and he said, I'm so grateful to you for what you're doing. And he said, you'd be shocked at how many of these kids got here because of a toothache. And I looked at him and I was like, I don't understand, and it took me a minute. We're taught in hygiene school, people are going to come in and they're going to say they have a toothache and they're going to tell you exactly what kind of drug they want. But I never learned in hygiene school that a child in pain will go to the medicine cabinet if that pain is not being dealt with. And a toothache to a child can lead to lifelong drug addiction. And as Mark Smith spoke to me, he said, you'd be shocked at how many of these kids got here and are addicted to drugs because they took their first medication because of a toothache. So now, it just inspires me. ToothBuds, our vision now is because no child should turn to drugs because of a toothache. So if that can help push the oral health agenda more into the medical field to make it more of a priority, because it's not just about teeth. Teeth have nerves and nerves are painful, and when a child can't get rid of that pain, they turn to the medicine cabinet. And we all know the atrocities that our poor children are facing because of drugs. So we are excited here in Graham and Greenlee County to utilize all of the legislation that you guys are pushing, because it allows us to be, as I said, the boots on the ground to put it into practice. So I appreciate everything that you guys are doing.
Thank you, MiQuel, and for sharing that inspiring story. That's very moving. And thank you for all the work that you do in Graham and Greenlee counties and Maricopa as well. So we'll move on to our next question, and I'm just going to pose this to the panel and chime in as you feel free. I know some of this information you already provided, but how does your innovative workforce model overcome geographic, financial, cultural, or other barriers that would otherwise limit access to care? And Dr. Hillier, you have your hand up. You're the first.
Virtual hand raised. I think there's ways to go about, a lot of people, particularly the financial aspect of it. So regarding your workforce, what's it gonna cost? How am I gonna be able to get these certifications? It's great to hear that you've got board members that are willing to pay for these things. Health centers can get really creative with scholarships. They can get really creative with tuition reimbursement, and not just health centers, but everywhere. And then you see their billboards and you don't realize it, because you might drive, especially for those of us rural, we'll drive miles, 50 miles one way every day. But the Arizona at Works program is really great. It's training professionals throughout the entire state for multiple aspects of employment. It's not just healthcare. So really being able to utilize that and advertising it and really kind of, going through those steps. But, particularly for dental assistants, the program goes through med certs, but it's great. It's a great resource. And we've had people that, worked in facility maintenance to say, gosh, I think I want to be a dental assistant, or I see that I can grow in this career. And so we help them get certified through those programs. So I really think it's great to notice what opportunities are there for you so that you can not necessarily reinvent the wheel, but just, lean on people that are there to help you.
Thank you.
I can add a little bit, Julia. So I think I'm really excited about how we could work closely with our community health workers. I've been working with community health workers for a number of years as well. And when I first started working with them, I didn't even know what they did. And I just love that workforce. And I think I'm excited about how we can work with CHW, CHRs, because they see our community more than a dentist does, or more than a physician does, right? They see them, I've even heard maybe 10 times more than the physician does, right? Because just for different reasons, whether there's a lack of transportation to primary care or dental offices, whether there's a fear of going in for those services, they don't go, but they do see a community health representative. So I'm excited about the interventions that can take place with that particular workforce. So right now we are in the process of standing up Medicaid reimbursement. Access did submit their state plan amendment, which was approved I believe it's approved. Don't quote me on that. I think it is approved, where they can reimburse for community health workers services. And it's a health education service that they can do. So I'm thinking about, okay, how can we use that reimbursable code for oral health? So now I'm trying to scan, what kind of oral health workforce curriculums, prevention curriculums are out there that we could then train our CHR, CHWs in, so that they can do that health education intervention with our community members, because again, they see them maybe 10 times more often than they would see a dentist or a primary care physician. And then I think also just their ability to educate and persuade people to actually seek their care. I heard a really great story just this past week from one of the doctors that works on one of the reservations, and he was able to really work closely with the CHRs throughout COVID. And because he was able to have, and kind of speaking to that medical integration with dental, right? But I'm going to consider the CHR as part of that dental workforce. They had that connection between the CHR and the primary physician. They went out into the community, basically to tell the client, come into the hospital so we can do these things for you, so you don't have to be in the hospital. So basically what they were saying is, if you come into the hospital with us willingly and we give you this treatment, it will prevent you having to be in the hospital maybe 3, 4, 5 weeks, right? So it was really interesting that the message that he was sending is, come into the hospital so you can prevent being in the hospital. But he said, I wouldn't have been able to deliver that message without that CHR. He really wasn't that messenger. It was the CHR that was able to convince the community member to come in so they could get that primary prevention for COVID. So I'm thinking, okay, if they could do it with COVID, how could we do that with dental oral health care? So real excited about what that could look like. We're standing up Medicaid reimbursement. I do want to say, which is kind of interesting, is that we passed the dental therapy law and we passed the community health worker voluntary certification law at the same time. We passed it in 2018. So you can kind of see how the different workforce models, they have a different timeline to move things along. But I think, again, really excited about CHRs and how we can incorporate them into oral health, dental health education. And then how we just incorporate them into our American Indian Area Health Education Center. I feel like those AHECs are more open to working with community health workers. They recognize that in some of our communities, especially the medically underserved areas, the communities that have these health professional shortage areas, that the community members are, we have to work with them in a different way. So we really, for our AHEC, we really embrace that grow your own model. So it just makes sense that we invest in our own community members. So that, because there's a greater likelihood that they'll come home. And that's something that really resonates with Indigenous people, that we want to go home. Home, this is our home. It has always been our home. So there's always a desire to go home. So excited about what that could look like within our American Indian Health Area Health Education Center. But the one thing I also probably want to add to that grow your own is, how do we grow our own, but grow them in place? Right. I know that we have across the whole state that we have shortages in different areas, but we invest in so much into our workforce, but then we have them trained for their last part of residency in another state and we lose them. I don't know if that's what that looks like for oral health, probably something we could take a little bit more research into, but with our CHRs, they obviously have a commitment to serve the community. They already speak the language. They are from that community, so culturally they are aware. It just makes sense that we invest in this community health representative workforce pool. So I'm excited about the work we can do in there. So this particular workforce, we are definitely going to target in terms of assisting them and kind of continuing through that pipeline. When I had a chance to sit down with one of the tribe's CHRs, and I think I was talking to about 6 or 7 CHRs, and I asked them, how did you get to become a CHR? What was your educational career pathway? And I think 6 out of the 7 of them said, initially I was going to school to become a nurse. That's what I wanted to do initially. But for different reasons, a lot of them women, and I think that's really important, is that this workforce is primarily women. A lot of the women said, for the most part, a lot of them said I had children. And so that kind of made me have to go a little bit different in terms of my educational pathway. But they came back to that kind of clinical space, so to speak. And they saw it with that CHR workforce, that CHR program. So they still have that desire to continue their education. So let's tap into them.
Thank you, Kim. Appreciate that perspective. And Kristen, were you going to chime in earlier? We have about 5 minutes left and we haven't even gotten to our last question, but I want to give you the opportunity as well.
Thank you, Julia. And I'll be brief. I just wanted to speak to a couple of aspects of the question, and one of them being how do we ensure geographic access, and then also overcoming cultural barriers. So our legislation actually limits where dental therapists can practice, and they can practice in FQHCs, lookalike clinics, nonprofit clinics that serve low-income and underserved individuals. And then there's a small open door for private practice dentists that see community health center patients of record on referral. And we didn't ask for that limitation. We weren't seeking any limitations, but I remember a conversation I had with you, Kim, about dental therapists early on in our thinking about going to the legislature. And the question you asked me was, how do we make sure that this profession doesn't just become another profession in the category of professional shortage area? Like, how do we make sure that these professionals actually get to where we need them, and that they don't end up in private practices in affluent communities? It'll be a long time until there are enough dental therapists to go around. So I think actually the limitations on practice areas is really healthy for this in getting good geographic representation. The other thing I wanted to mention is, because of the way dental therapy came about, it was Alaskan tribes in 2004 sent dental assistants to New Zealand to be trained. And so dental therapists have been working in Alaska for, since 2004, providing services. And I think that dental therapy, that perspective has continued in all of the training of dental therapists, and the way we talk about dental therapists, and the way dental therapists are utilized in really resulting in a pursuit of culturally competent care, and a recognition, and there's more and more recognition out there every day about how important it is that our healthcare professionals, dental professionals are able to speak to their patients in a way that their patients understand, and also in a way that builds trust with those patients. And I think that's part of dental therapy history. I think it's critically important, and it's something we need to make sure that we continue to emphasize as dental therapists get trained.
Thank you. Okay, one last question, and we have 2 minutes left, but I wanted to reach out and find out which innovations are you most excited for or feel are really promising in addressing need and access to care. It's probably not a 2-minute question, but I see some things coming through: EFTA, dental therapy. Anything the panel wants to throw out?
I can address that really fast. If for tooth buds, having a dental therapist travel into these rural communities with us, where we go up into Greenlee County, there's not a single dentist in the entire county up in Greenlee County. And so to have a dental therapist go alongside of us is going to be a game changer. Parents work at the mine up in Greenlee County, and they're not willing to take a day off to bring their kids down to town to get their teeth cleaned and go back up. So that's why we're so successful in Greenlee County, because these parents don't have to take a day off work. If we can bring the dental therapist with us, that's going to be a game changer for Greenlee County, where they're an hour and a half away from the closest dentist. So I'm really excited about this.
Thank you. Anyone else?
I'm really excited about the conversation around integration and integration of care. And I know that's something that community health centers have been working really hard on, and really finding ways to connect oral health and medical health, because we know so many more people will see their physician than will see the dentist or an oral health professional. So I'm really excited about the opportunities that intersection provides, and incorporating more and more dental oral health information and access to care into the medical side. And I don't remember who said it earlier, but someone said, I don't know when the mouth got disconnected from the body, but I'm really excited about the reconnection of that.
Yeah, I think I'm other than what we already talked about, I think I'm excited about working with our community, community colleges, and for our communities, our tribal colleges and universities, and how do we start to work with them so that they can implement dental therapy curriculum, CHC curriculums, whatever makes most sense for their community.
Well, thank you. I want to extend a sincere thank you to the entire panel, and bringing your challenges, but also very promising opportunities as we move forward in the near future. So thank you again, and I will turn it, I believe, back over to Tara or Brianna.
I think it comes over to Tara right now.
Yeah, that's me. I'll see it out. All right, that was such a wonderful conversation. Thank you, everyone. Thank you to all our panelists and to our incredible moderator. It was so inspiring to hear about all this amazing work that's being done. I just wanted to take a quick minute to summarize some of the key themes that was going on in the panel conversation and in the chat. So we see that Arizona has a high oral health need, and expanding the oral healthcare workforce in new ways can bring care to the people where they're at. Thankfully, the one thing that it sounds like we don't have a shortage of is passionate and dedicated advocates whose work will get us there and get us to that high level of oral health as part of overall health. I loved hearing the overlap between the topics of workforce models and also like advocacy and integration and teledentistry that was popping up during the conversation. It really shows how, even though we all have different backgrounds and perspectives, we all share that common vision and can work together to promote oral health as essential. So thank you all so much again. I will pass it off to Tammy.